your clear presentation. We were asked by one of our guests, who is a foreigner, to speak in English so that he can follow the session. And now I am very to present Professor Eman Ragab. Professor Eman Ragab is an eminent professor in Ain Shams University in hematology and oncology, pediatric hematology and oncology. We are very proud to have Eman Ragab in the Ain Shams team. She's very dedicated to her patients. She's one of the most honest physicians I've ever seen in my life. I'm very proud to present Eman Ragab. She will give us a presentation about antifungal disease. Thank you very much. Go ahead, Eman.
Okay. Bismillah ar-Rahman ar-Rahim. I would like to thank you, Professor Ilham. You know very well that you are a role model for all of us for the sincerity, and we are very proud for me to present while you are chairing the session, and I'm indebted to the whole pediatric ICU team. They know very well that I love them very much. They are on our back in every single patient who gets critical. And I'll start my presentation by taking the, I don't know, the slides are not, yes. Are the fungi that we are eating the same fungi that we get infected with? There is more than 100,000 species of fungi. The microscopic fungi that causes illness inside the human being are either molds or yeast. The fungal infection either are superficial, that usually we encounter like tinea capitis, like dermatophytosis, but I'm concerned today with the deep mycosis. Where do fungi live? They live everywhere, and especially I want to highlight that whenever we are in the hospital environment and we have construction, we have to make the very strong curtains and shields around the construction area, because after the construction usually the patients get significant fungal infection. They live on the top of cockroaches, they live in the black pepper, so this is the site of concern of probable presence of fungi. The fungi are divided into yeast, like the prototype is Candida species, and Cryptococcus neoformans are less common, and molds. Molds are divided into Aspergillus, Penicillium, Fusarium, Cytosporium, and Mucor. Why are we talking about invasive fungal infection? Because even in the 2000 years, and even in Japan, in hematopoietic stem cell transplant, mortality rate due to invasive fungal infection had topped up to 50% in some settings. Our talk will be about antifungal decision to diagnose and decision to treat. So whenever we take a decision to diagnose, we have like plotting a certainty chart. When we're not very much certain of diagnosis, it's called possible. When we're more confident, it's probable, and then it's proven. Proven fungal infection is not an easy job to attain, and usually we do not attain a proven fungal infection. And those definitions are based on these definition published in 2008 on the invasive fungal infection by the European Research and Treatment of Cancer Group and the Mycological Study Group. They plot definition based on some host factors, some clinical criteria, and some mycological criteria. When host factors are present with the clinical, suggestive clinical criteria and mycology in the form of blood culture and tissue, it's called proven infection. When the mycology are not certain and they are indirect, it's called probable. When there is no mycological criteria, it is called possible. And when the host, only the host factor with the mycology and asymptomatic patients, it's not in these criteria classified. What about the host factor? The host factor, for sure, it means immunocompromised host, either by prolonged neutropenia more than 10 days and less than 0.5 per microliter, or the presence of immunodeficiency, especially affecting the innate immunity and the T cells, or by medication attacking the immune system, like prolonged corticosteroid use, like allogeneic stem cell transplant and T cell immunosuppressant agent. Going to the clinical criteria, if you are found in the trachea ulcers or black scar, in the radiology, this is very important to in the 4 signs suggestive of fungal infection, either nodular lesion or a nodular lesion with a halo sign around the nodular region, or going into a air crescent sign, which is progress of the lesion and then cavitation. Those are the signs in the radiology suggestive of invasive fungal infection. And continue to the clinical criteria. If I find a sinusitis with a mass are eroding the bone around it, usually it's an invasive fungal infection, although there is other differential diagnosis, but the invasion for itself makes us think of fungal infection. In the presence of CNS lesions in a suggestive clinical setting, this is very suggestive. As regards the mycological criteria, we have either direct tests to find a bronchoalveolar lavage or sinus aspirate with presence of fungal element, this aspirate or bronchoalveolar lavage, or the recovery of a culture of mold like Fusarium or Aspergillus, or we have indirect test, and in few seconds I will mention the galactomannan testing. The indirect test is the cell wall constituent of the fungi. To have a proven fungal infection, for sure fungal infection, I have to document either blood culture with fungal infection, either a mold or yeast, or to have a histopathological confirmation of inflammatory reaction, and inside the inflammatory reaction of the mold, the part of the fungal element which was not encountered in the case, unfortunately, or to have a CSF with presence of cryptococcal antigen inside the CSF, and the cryptococcal is very common in the HIV population with very low CD4 count. This is for the first decision to diagnose. The second decision is decision to treat. We have several groups of antifungal agents, the azole group, the itraconazole, and I want to mention that the itraconazole formulation in Egypt, their capsular form do not have the solution form, or we prepare it, and the solution form has a higher bioavailability. We have the voriconazole, posaconazole, and the very famous fluconazole, the echinocandin, caspofungin, and micafungin, and the polyene group, like the amphotericin and its formulations. The polyene group, which is the amphotericin, cause like a tubular or disrupt the membrane, and they are not specific for the wall of the fungi. They do the same for the renal tubular system, and that's why the nephrotoxicity is very common in this the polyene group. The azole group, they inhibit the ergosterol synthesis, so they are less toxic as regards the membrane toxicity, and the echinocandin, they inhibit the beta-glucan, so the toxicity profile is less. And there is long life timeline of the antifungal agent, and whenever resistance show up, another antifungal agents show up, and we have recently an anidilofungin present in Egypt. The decision to treat, we should consider sensitivity, toxicity, and for sure the cost, because they are expensive medications, and the toxicity profile for example, for the amphotericin group, amphotericin B lipid complex or liposomal form, they have still nephrotoxic effect. So this is one of the points that we should consider during the decision taking. During decision taking, we have two policies, either proactive or reactive. Whenever I have a very high prevalence of fungal infection, like hematopoietic stem cell transplant, I advocate for prophylactic. Prophylactic is a proactive, not a reactive. And whenever the fungal infection is less, I would do a symptom-based or diagnostic-driven approach to treat. This is the different approach. And whenever I take a decision of antifungal agent, I have to put on consideration the published data about the sensitivity, yet we have to do an institutional-based sensitivity pattern, and this is very important. So I want to mention that for our institution in Ain Shams University, we have lots of Candida glabrata, which shows less sensitivity to fluconazole, for example. And we have lots of Aspergillus fumigatus, and the sensitivity still for fluconazole species is not very much high. The mucor, because I want to mention the mucor later on, is not sensitive to most of the antifungal agents, so it's sensitive to amphotericin B, which different formulation. During taking the decision for antifungal strategies, I may do prophylactic, empiric, preemptive, or very specific treatment. This depends on the likelihood of the infection at the proper. So whenever I have prophylactic, I do not, before development of symptom, if I have symptom and clinical criteria, I would do empiric treatment. If I have mycological criteria, I would do preemptive treatment. If I have tissue diagnosis, I would do very specific antifungal management. I will just mention few points about each fungal infection. In the Aspergillus fumigatus is the common organism you encounter in our daily practice. In the invasive fungal infection, basically we have a nodular lesion with a halo sign and then air crescent sign. This is very common in the Aspergillus infection. What about the galactomannan test? The galactomannan is, for now, the commonest test used to diagnose fungal infection. There is no cutoff level in the pediatric age group. 0.5 is the cutoff level in the adult population. In the pediatric, we depend on a rising fluorescent of 0.5, 0.3 about the rising titer. If it's 0.2, it rose to 0.4, so it's considered infection. And I want to mention that some of the antibiotics you are using, like tazobactam, for example, give false positive galactomannan testing in the during the treatment, and the fusarium species which we started to see during our practice is give false positive result with the galactomannan. The beta glucan are less commonly used. The PCR up till now they're not validated for diagnosis of Aspergillus infection. Recommendation of Aspergillus for first line voriconazole. Yet I want to mention that with the azole group, we have to do therapeutic drug monitoring if they fail treatment, because many drug interaction with the azole group. So I cannot declare failure of the azole group except if I do a therapeutic drug monitoring or TDM. As regards the candida, the invasive candidiasis usually is not commonly caused by albicans only, but also the non-albican species. I want to highlight the presence of Candida glabrata and Candida cruzi, or cruzi. And whenever I look at the fungal of the culture, please double check the MIC, because if it's high MIC, I have to choose the antifungal agent with low MIC. And during the invasive fungal infection, the number one choice is echinocandins, although we are usually using fluconazole, yet because of the emergence of the non-albican species, so there is decline in the use of fluconazole as first line in invasive candidiasis. So again, caspofungin and mycofungin, they are used prior to fluconazole in the invasive candidiasis nowadays because of the emergence of the non-albican species. As regards Cryptococcus neoformans, we usually cause CNS infection. It's been thought with the treatment of the complication of HIV. It's detected by CSF analysis of cryptococcal antigen. As regards the mucormycosis, which is, I guess, the child you presented, Dr. Summer, probably it's mucor. It's a rapid onset of tissue necrosis. These are the clinical picture: fungal eroding sinusitis causing proptosis, usually a black scar because they do pigmentary changes, and it erodes the sinuses and goes to either endogenously to occlude the nasal cavity or exogenously to appear on the skin. And the mucormycosis may cause pulmonary infection with angioinvasion. And we lost one of the patients because mom refused to do surgery because the angioinvasion may cause aggressive severe hemoptysis. The cutaneous mucormycosis gives a black scar, and this is the clue sometimes. In gastrointestinal, we do not see it commonly, and disseminated, we do not see it commonly. The mucormycosis diagnosis, we do not have a serological test. They should have a biopsy with mucor inside the biopsy of inflammatory reaction. This is very important to highlight that whenever I suspect or I prove a mucormycosis, the conventional treatment is not valid. So we have to use very high dose of amphotericin B, reaching to 10, even sometimes milligram per kg of liposomal amphotericin B. The minimal dose is 5 milligram per kg. It's not the regular 1 to 3 dose we're using in the invasive aspergillosis. The second line is posaconazole, but it is FDA approved more at the age of more than 13 years. It's not FDA approved less than 13 years. Let's not forget that the Pneumocystis pneumonia or Pneumocystis jirovecii is one of the antifungal fungi. Now it's classified as fungi. And whenever I have immunocompromised host with interstitial pneumonitis, I have to think of Pneumocystis jirovecii as well. And I cannot end the talk without mentioning that whenever I treat COVID and the patient is not responding, please think again that there is super added fungal infection. And this is one of the cases which was recently published. And they found that the patient did not respond well to the treatment. And when they added voriconazole to the conventional treatment, the patient marvelously responded and was extubated. And I'm very indebted to the group. I'm working with the hematology oncology group. I hope that we have like antifungal strategy in our institution, because many of the department are using antifungal agents, and it's not like an antifungal stewardship should be done in the hospital. And thank you.
Thank you very much.
Thank you very much, Eman. Thank you for the first theme today, Summer and Eman. Summer made a very clear presentation, and Eman gave us very valuable knowledge about fungal infections in pediatrics.